sitting.
Maybe irritability or
Yeah,
activity.
so potentially irritability, and also some things can be against gravity versus with gravity. So I'll just, again, show you some things here. Usually, most clinics have a wedge. The Colton-Born wedge is the other one that's really spongy and a little bit better than this. This is the NOI wedge, which is really pretty firm. I showed a couple of you how to do thoracic spine techniques on that the other day. But basically, you do that, and this can kind of keep the wrist in a stable position for you, because as you stabilize the wrist, if you come down here, she's not really going to move. Okay. So usually off the edge of the table is good. If you don't do that, if you don't have a wedge, students do this, and when she goes through flexion, she hits the table or the towel, and that's not true flexion, right? So your range of motions are there, so she should have at least 80 to 90 if she does that. Again, we're cheating her the motion. She really has. Still cheating her the motion. That. Okay. So let's go through these guys. The other thing I want you to consider too is the position of her arm. So slide back first. What's the difference of that versus now slide to 90-90 versus that? What changed? Elbow. What about the elbow? And how would that affect the wrist? So let's say she goes back. So if I look at that versus if I look at wrist motion like that.
Open pad.
Not necessarily open pad. So I heard a little bit of it. So tendons are what? Muscle bellies are stretched if she's like this or if she's like that. Yeah. So what is this similar to in the lower extremity? Not necessarily the knee. The ankle. What about the ankle?
When you're testing dorsiflexion, if your leg is extended, then you're pulling on gastrocs.
Right, gastrocs versus if the, correct, so if the knee was flexed, then you're looking at pure cervical motion. So similar here. So if she's here and that's extended, and we're looking at some of her extensors, if they're tight, they're going to give you this, kind of appearance that she's limited in this motion, right? So again, if you're looking for length, obviously you can do that to stretch length, but I think standardize your position when you look through the wrist, and I probably would say use the shortened position so that you're looking truly at the joint component. Okay. All right, so let's have, so she's going to be here. Okay. So I'm going to have her go through the motions. I'm going to have her do wrist extension first. So basically I'm just stabilizing kind of her distal radius and only here. She goes through wrist extension. Could I measure this? Yep. Do you remember how to measure this from kines? Okay, good. So you should be able to measure wrist extension. Does she look like she has the normative value there? Yeah. Again, you could look at that. You could have her come through again, do it again if you wanted to. And I basically come fit into this hand, and then I overpress like that. That's it. And I take her out of that position. Super easy, right? So she goes ahead and extends. I come in, again, asking about symptoms. She says, fine. Let your fingers relax. And then I just pull this in. And that's extension with overpressure.
Would you always want the fingers open?
I would actually like them relaxed. So she can actively do that if she wants to. She's probably not going to do that. If she is, I probably would just have the fingers relaxed so you eliminate the extensors. And then when you come in, totally let her relax on you, and then you get a fair assessment of the joint end feel. Okay. And then wrist flexion, so go ahead and flex. So I would say, she's kind of hitting there if I overpress her. Go ahead and come out for a second. Okay. Stabilize her as best I can. Good. And even here, look. She's got a lot, right? Slide it forward a little bit. Okay, go ahead and go through this section. There we go. And there's her end range. So same thing coming through. She does actively first. I come in, stabilize distal radius only. Do that. Take her out of the position. Pretty simple. Radial ulnar deviation. And again, if you look at that here, that's really against gravity, right? Because she's going this way, these two directions. So she could basically bring her thumb towards her. Again, stabilize, hold onto her hand. There's the radial deviation with overpressure. Kind of just coming through, lacing through, and then just compressing through metacarpals. And then ulnar deviation towards me. Stabilization. And here we go. Which direction should have more motion? Radial or ulnar? Yeah, do you see that with Kenzie? Radial, ulnar. Okay. Supination, pronation. So we showed you in supine this thing, but to kind of get a little bit more of the distal component, you want to do kind of this handshake component. Come up a little more. And I just lightly stabilize here. Go ahead and supinate for me. I come in, handshake, and I do that. Good. Go ahead and switch, and do that. Okay, just so I capture more of this joint complex versus doing this, where I'm kind of eliminating it. Pretty simple. Okay, supine, really quick. So go ahead and go supine. And it might just depend, again, against gravity, with gravity, whatever you want to do, as well as where you might want to mobilize if you don't want to move the patient per se. Okay, so she could do the same thing. She could go through wrist flexion here. She could go through wrist extension here. She could go through radial deviation, ulnar deviation, and I could come through and do supination. Go ahead and supinate. And then I could come through. Go ahead and pronate. And I could come through. Sometimes, again, the difference is that this is shortened, so you could come up here. Go ahead and wrist flex. Against gravity or with gravity? I hear against and I hear with. Yeah, why? Yeah, so again, you could play with these positions. I like this because it's shortened, so we don't have the contribution of a tight muscular or the ECB or the flexors, depending on what we look at. So she could go through that motion, go ahead and flex. I come through, over press, go ahead and extend. I stabilize, come through, fingers relaxed. Good, she can radially deviate towards her. Over press, ulnar deviate, over press, and then supinate. Shake, pronate, switch hands, pop. Okay, so what I don't want to see in a practical is if you're doing this type of stuff, this is loose, and you're losing this component, or you're not holding her in the right position. Okay, but you can choose between sitting or supine. Okay, so go through those. And again, if you need to palpate a little bit, I'll keep the palpation slide up, just so that you're familiar with some of that stuff. Again, we'll go through the carpal joints in a second, but make sure you practice those both in supine and sitting. Okay, and there's the instrument. So again, this is on your handout. You have a picture of the positioning. The nice thing about this glide is that you go one way for the AP and the other way for the PA. You can also switch, so you can glide ulna on radius and radius on ulna. There is some mention of concave convexity with how you're pushing, but I would just say, again, if somebody's lacking certain motions, push one direction. If they don't get it, push the other direction, for the most part. But again, state board exam and things like that still are pretty important about concave-convex relationships. So again, this is Kenzie's hand. Hi, Kenzie's hand. How are you doing? Good. All right, so the patient is positioned in supine. Again, you could do this in sitting as well. The clinician uses what they call a pinch grip with both hands and places the thumb pads on the radial and ulnar styloid processes. So basically, I'll bring her arm down. I don't know if you guys can see. How about I do this, and then we'll flip over there. Okay, so I'll be here. So again, I can stabilize her arm with my forearm here. There's a towel there just to kind of keep her still. But and really for her, this doesn't necessarily matter because I'm mobilizing something here. So whatever position is comfortable for her is really what matters. So thumb pads basically on the styloid processes. And then if I wanted to glide ulna on radius in a posterior direction, I stabilize radius, kind of, so here's the radial styloid process. I'm kind of pinch gripping that with the pad of my index finger on the other side. That's holding the radius still. This guy basically pinches the ulna, and then there's the posterior glide of the ulna on the radius. So what motion does that look like is occurring? Pronation, right? So again, that's a simplistic view of that, but that's what I would use that for. So again, that's the posterior glide, so anterior posterior, of the ulna on the radius. What do you think the anterior glide would look like? Yeah. The thing is, when you feel this, it doesn't move a lot. Okay? So in theory, that does create a little bit of what? Pronation, and that creates what? Supination for that. Okay. So again, that would be radius stable, ulna moving in a posterior or anterior posterior direction, and posterior to anterior direction. You could mobilize it as you would anything else, grades 3, 4, etc. 45 seconds for pain or for hypomobility, or grade 1, grade 2 for pain relief. But in theory, we'll go through a distraction technique, which I would probably do more for pain relief as we did for other joint sections. If we ended up wanting to move the radius on the ulna, again, I could stabilize ulna, right? Hold ulna down. Here's my hand pinching the radius. This is the anterior to posterior glide, and that looks like what motion? Supination. Here's the posterior to anterior glide. Pronation in general. If you are in a practical situation where you are mobilizing a patient here, just make sure that I'm not seeing a lot of this or this. There has to be one component that's stable and really one other one that's moving. The way we see that as instructors, if I see full motion like that, then I know you're not stabilizing one of those two parts. Okay, pretty easy on that. So again, you can play around. I can be in this position if I wanted to see her face, see how she's doing, and I could just reverse my grip as long as I stabilize, let's say, radius, ulna, and then what glide is this? AP of what on what? Of ulna on radius. What's this? PA of what on what? Yeah, and then if I switched, what's this? AP of what on what? Good, and if I did this? That really doesn't move a lot. Okay, pretty simple. Jen, can you scroll down just so we get that next picture? So let's go through. So really, that's just distal radial ulnar joint. That's all you have to worry about there. Distraction. Now again, the resting position of the hand is up to you. However you want to hold that position, and patient comfortable, however position that they're comfortable is really the key. It's resting on the table, the wrist supported with a towel. Again, I could have Kenzie slide over just a little bit, so I could have more of her hands supported here. Okay. The clinician grasps the distal kind of radius ulna component, because what are we moving on what? So if I'm grasping radius ulna, what am I moving here, or what am I creating space in between?
Carpals.
Yeah, so which row though? Proximal or distal? Proximal. So that's really all you're doing. So again, you can play around with stabilization here of the radius ulna. This hand comes up. Basically, I use the pisiform to feel my way on the carpal row, and then wrap around. That becomes my landmark, and then there's the distraction. Okay, really comfortable. I could likely do it in different positions. So if she was up here, I could, again, stabilize radius and ulna, and I use the styloid processes for that. Come here, I can use this part of the web component of my thumb to feel for the pisiform, and then there it is there as well. Okay, so you can do different positions. This to me would be more taxing on my arm and hands than this would be, because I could just pull into the distraction. And then this one likely is going to be grade 1, grade 2 for pain relief, 60 seconds to mobilize. Okay. Scroll down again. Let's go through the AP and PA glide. Now the key thing is for the hand position for this. So we're going to look at, we'll do supine and we'll do it in sitting so you can see both positions. So what position is the hand for the AP and PA glide? Is it like this or is it like this? What do you think? It's supinated, right? So again, you can slide towards me a little bit. And sometimes for these, I'm likely going to stand. You'll find that when you're moving or doing the AP and the PA glide, you can do this, and you can switch it around and go that way. And then when you do the radial and ulnar glides, you're likely having the hand go like this, and you're going this way. Right? You glide that way as well as this way. And we can show you again in both positions so you can see. So let's do the first one, the AP and the PA glide. So she's supinated first. So what am I stabilizing? I'll just do this so you can see it. What am I stabilizing here? Distal what and what?
Radius and ulna.
Okay, and where's this hand going? Proximal, right? And then if I wanted to do the, let's say, anterior to posterior, which direction should this hand go? Towards me or towards the floor?
Towards the
Yeah, that's it. So that's it. Now I don't do this back and forth. I don't go AP, PA, AP, AP. So I really stabilize her here, make sure that she's locked up there at the distal component, and then come through here, and she's got a nice wrist crease that kind of separates that for me. And then that's the glide. So that's the anterior to posterior glide. Okay. I could have her do this, and the elbow a little bit. And then what's this glide? Yeah, so you can reverse them quite easily. In the clinic, it is, I mean, I have seen hand therapists do this. They'll do the AP, no, not getting it, and then they'll do the PA. She's a little bit looser going, a little crunchy going this way. Okay. Let's do the rest sitting so you can see what that looks like, and we'll do the radial and ulnar one next here. So let's see here. So a lot of times you'll see this. Okay, so what glides that? PA, good. And I have the towel roll. Sometimes I'll do that and then kind of come underneath. And that glide? Good, and this glide? Good, so then what would be that glide? Medial glide, right? Or lateral to medial, but really medial or a ulnar glide. And then really if I want to do radial glide, what would I do? Yeah, I could do this, but again in this position it's probably easier for me just to then pull upwards and do radial glide. So radial glide, which would be lateral, medial glide, ulnar. This would be the what? Posterior to anterior. Anterior, posterior. Okay? Again, it's a structured format to go through basically joint articulation. So all you're trying to do is an accessory glide. One is stable, you're moving the other one on top of it. Dr. Cipriani and I were talking, and I think that the value of this experience is that, give me your hand, Haley, for a second. There's no way, unless I have my x-ray vision, as Dr. Cipriani had said, to know if I'm 100% doing that. So I think you have to respect the fact that your palpation skills are not going to likely be on that exactly, but you just need to know the anatomy and have some appreciation for those movements. Things like the capitate and the scaphoid, you know, if you come into that anatomical snuff box, what are you going to feel there? You do it on yourself, right? That is, I mean, that's pretty palpable, but to try to measure the motion, right, of the trapezoid on the capitate, forget it, right? That's super difficult to do. So just as you have your partner go through some of the anatomy, make sure you guys both know it, as well as go through some of the glides in this order just to kind of get a sense of where things would go in terms of palpation and in terms of joint gliding or accessory motion. So the first step, so will be the first four in black. So you have the capitate fixed, which is this one, right? We're all clear with that. So that's your capitate. So the capitate is stable, and then we move the trapezoid. But what did I say in kinese? The trapezoid is almost what? Palpation-wise, again, that's probably going to be the smaller of most of these. Very difficult to move, and you're asking me to come grab that and move that and glide it on top of a stable capitate. It's difficult to do. But think about where it's at. Try to stabilize the capitate. And again, I'm coming through the hand like this, which in reality is probably like that. And then I'm trying to move the trapezoid in an AP-PA direction. That's all we're doing. Okay. So step one, stabilize capitate. So I pinch capitate, and I'm moving what first? Trapezoid. Okay. What's step two? Fixate capitate, move. A little bit easier to do, right? Because again, you can feel the scaphoid a little bit easier than you can most of these guys. So again, I'm fixating capitate, moving the scaphoid in what? AP-PA direction. What's third? Lunate. Now, you can do that. You can also switch. So now you're on this side of the hand, so you've stabilized here, and you're now moving lunate on a stable what? Capitate. Okay, what's next? Hamate. Oh, okay. Yeah, so again, so stabilized capitate, we finished lunate. Stabilized capitate, we're moving now. Hamate, and how do we find that? Yeah, there's that little hook right there. So if you come off that hook, sink in, you're likely on the hamate as you're stabilizing the capitate and you're moving it in the AP direction and then PA direction. Again, there's soft tissue here. So you're doing really this, you're not doing that, okay? But have an appreciation for where they are and what you're trying to do anatomically. So now that you're done with that, you go on to what? You're fixating the scaphoid, and now what are you moving? Trapezoid and trapezium, which are its neighbors right here. So oftentimes you can come in like this through the anatomical snuff box, grab it like that, theoretically grab, what's the small one again? Trapezoid, and you're doing that glide. And then theoretically, what's this one? Trapezium, and moving this one. Okay, so we're done with that. Fixate the radius and move the scaphoid, probably one of the more simpler ones. So again, stabilize radius however you want to efficiently and effectively. So you might want to grab this. And then what are we moving on top? Scaphoid. So the problem is that you might move the entire hand. So if you can somehow grab the radius and the hand at that same time and then move scaphoid, that's even a little bit better. And if you ulnar deviate, that opens that space up a little bit, and theoretically you're moving the scaphoid on the radius. Okay. Let's see, fixate radius, move lunate. Again, we're switching. Again, I grab the radius, probably part of my hand's grabbing their hand, and I'm moving what? Lunate, right? Okay. Now we move to the ulna, so we fixate the ulna, then what are we moving? triquetrium, right? So, and what's in this area right here? The TFCC, right? So again, there's really no hard articulation besides the TFCC here for the cartilage component. So again, we're stabilizing the ulna and then we're moving triquetrium as best we can. So again, I kind of find that you come over, you grab either like this and the hand, or like this with one hand, and then try to glide it like that. Again, theoretically, the hand's going to be, again, you're moving a lot of stuff besides that, but just again, go through that process so that you know kind of where the anatomical components are. And then last but not least, the triquetrium, and then you're moving what? Yeah, so really coming underneath the pisiform, if you come under that, you're usually on what? Triquetrium, and then you're just grabbing that pisiform, which shouldn't move much, if any. Okay? So I know it's tough. We'll keep this up here, pass this around, go around through your partner. Just again, try to find capitate. If you can't find that, look at the palpation slide 1 or 2 before, where I talk about the metacarpal and where it aligns to. So make sure you're familiar with that. Try to stabilize that, and we'll walk you through theoretically trying to glide in that order. Okay? All righty.